So we'll talk about chest anatomy and with focus on chest radiographs. So we're going to review the techniques, anatomy, interpretation, and pathology. A lot of the materials were taken from the University of Virginia radiology module, which is with the link below, so you can get details there if you want. So you guys had a quiz, and here are some of the questions from the quiz. You could just shout it out or text your response in. Opacification of what part of the lung will silhouette out the left heart border? Left lower lobe, superior segment of the left lower lobe, right middle lobe, or lingula? Superior? Okay. Any other guesses? We'll review these questions as we go through the lecture slides. Lingula? Okay. What is the likely diagnosis in this patient? Atelectasis, pneumonia, a pulmonary edema, or pneumothorax? So it's a frontal chest radiograph. Pulmonary edema, okay, so it seems like the edema is the consensus. Identify the objects labeled 3. What's 3? Aorta, aortic arch, epicwindow, atrium. Ascending aorta, okay. And then what do we think 4 is? Atrium, okay. And number 5? Arch. And 6 and 7? What are you doing? 6 is? AP window. And then number 7? Any guesses for what you think number 7 is? Left ventricle, okay. Any other guesses? I guess we don't really have a good response for that here. 6 is not part of, 7 is not part of the question. What's the likely diagnosis in this case? A right middle lobe pneumonia, right upper lobe, right lower lobe, or right upper lobe atelectasis? Okay, right middle lobe, okay. Right middle lobe, good. What is the abnormality that we see in this case, or the name of the sign? Left lower lobe atelectasis, the left sickle sign, Hampton's hump, or none of the above? Any guesses? It's this wedge-shaped opacity here in the left lung fields. Hampton's, okay. Hump, okay. What other signs or symptoms would you expect in this patient? An enlarged or lymphadenopathy, hypoxia, normal D-dimer, none of the above. So the consensus looks like maybe hypoxia and dyspnea. Identify what is this bronchus here? The name of this bronchus, 23. So this is the main bronchus, and then this is west. So we think it's a right middle lobe bronchus. Okay, any other guesses? 2, right middle lobe. Okay, so I think everyone, consensus is a right middle lobe bronchus. What about the 24? So the bronchi extend to each of the lobes and then the subsegments. So we think the left is maybe left middle lobe bronchus. Okay. Left middle lobe. Any other guesses? So we'll review some of the lobes. Okay. Identify the abnormality. So we have a frontal and a lateral radiograph. What is the abnormality? Right pleural effusion, hydropneumothorax, right basilar pneumothorax, or right lower lobe atelectasis? Right. Any guesses? This is an interactive section, so so we think it's a right pleural effusion. Okay. Okay. So maybe a hydropneumothorax. Okay. We'll review these questions. So possibly it's maybe B is the winning choice so far. Hydropneumothorax. And what sign is seen in this image? Concave sign, indistinct sign, crescent sign, silhouette sign, or all of the above? Any guesses? Okay, so we'll review that. What finding is least consistent with lobar atelectasis? Air bronchogram, crowding of the vascular markings, expansion of the other lobes, elevation of the hemidiaphragm. Any thoughts? C? Okay. Least consistent, we think, is elevation of the hemidiaphragm. Okay. Any other thoughts? D, none of the above. Okay. Which of the following characteristics of calcifications in solitary pulmonary nodule would be considered benign? Or would be considered benign except which one? So only one is considered suspicious or malignant. Which one is considered malignant or suspicious? D. Complete calcifications. C. Irregular calcifications. Okay, so C. Okay, great. So we'll go start off with positioning. So a standard radiograph has two positions, PA and lateral. So this is an example of a PA. This is the detector, and the radiation source is coming from this side. So if you had a flashlight equivalent of the radiation, the flashlight is here, it's beaming here, this way. And then this is the detector. So the photons that are being passed through the radiation will then pass through this patient's lungs and then be captured in the detector, which then generates these images. And it's taken on an inspiration, so a patient takes a deep breath in, they get their shoulders out of their way, either like this, or they put their arms overhead to get the shoulders out of the way so you get a better image of the chest. This is a lateral radiograph. So here, where patient is on the lateral, arms up and over, because if you have arms within the field, it'll obstruct the field of view. And patient takes a deep inspiration, and then the radiograph is captured. So the importance of AP and lateral views in radiographs. So in radiology, we have the saying, one view is no view, and this is the reason why. Because when you have two views, you can then localize, and whatever you're saying, you'll have a higher confidence. And you're just a lot more accurate. So one view is no view. So I know we do a lot of portable radiographs, and it's fine. Portable radiographs are fine when patients are sick, they can't leave the ICU or whatnot. Understandable. But whenever possible, patients should come down to the radiology and get a two view for this exact reason. Because when you have a finding, it's hard. First of all, you need to verify that it's a finding, and the quality is better when the patient comes down to the radiology department because of these quality metrics in place, right? Patients are positioned correctly, their arms are out of the way, they take full inspiration. So whenever possible, get a two view because you get better imaging. In radiology, we say old is gold, and so having prior radiographs, even if it's done at the outside hospital, not just radiograph, I mean any kind of imaging, it's really helpful to have it in the system at the time of interpretation because it'll markedly increase your level, the information you can relay. The lateral radiograph is obtained with the patient sort of in the lateral view. Which ribs are left and right? So this patient right is closer to us and the left side is away from us. So if you look at this image, which set of ribs is right or left? The one that's bigger, this one, or the one that's smaller? Here. Any guess? Bigger is closer. Yes, exactly. bigger is closer. And this is, you get magnification effect. So if you can imagine you have a flashlight, and let's say this, you know, you have a flashlight and you have your hand here. The closer your hand is to the flashlight, the larger it's going to be. And the blurrier, right? You can imagine putting a flashlight on your hands against a garage door or something like that. So the farther the flashlight is from or the closer the flashlight is to the detector or the wall or the garage door, the crisper the image, the better the resolution, but the smaller the image. So there is that known effect that we see with radiology. So and you can use it to your advantage because you know the spatial relationship, you can then help localize the abnormality if need be. So which side is the right and left hemidiaphragm? So which is the right diaphragm? The one that's bigger, like the one that extends to the back, or the one that extends to the, I guess, sort of more inner aspect of the image? Bigger, yeah. So the image on the right is going to, the diaphragm will extend out to the pleura. So you see this one, so it's the right side. And then the left side is the contralateral side. You can also look at the heart silhouette. Sometimes it helps to identify which side you're on. But hopefully if you're going to get a lateral, that means you got a frontal. So that's another way to localize the abnormality and characterize it. Here's a lateral view. Heart is on the left side. So the patient here, the patient is heart is, so what we're telling you here is that the heart silhouettes out the left side. And so in the left, here you can see it outlining. So we know that's the right side because the heart sits on the left side. And here we see that diaphragm, we kind of lose it. So that's where the left side is. Positioning. So there's different ways to position. We saw here, a typical AP lateral is upright. So patients stand up. But sometimes patients cannot stand. So then we get a supine radiograph here. We can also get supine radiograph for other reasons. For example, if we want to see fluid layering, patient, let's say we're concerned about a pleural fusion. So we can put them on a right lateral decubitus, and then you can see the layering fluid, and then you can get a better, so understanding these structural relationships help because you can then use this positioning to then manipulate it to figure out and answer your question. This is also true in abdominal radiographs because, for example, patients with bowel obstruction, if they are supine, then you don't see the fluid levels. When they're upright, you'll see the fluid levels. So that's one way to use positioning to your advantage. This is also important in the setting of like pneumothoraces. You can have them upright, expiratory position to make the pneumothoraces more pronounced to bring out the abnormality. So Sumed has a question. Can trace out the whole two diaphragms, right and left, in the lateral view. What's your question? I think your question is, we can see the diaphragm both sides. Is that right? Okay, can you point out the left and right again? I see what you're saying. So we can see the both diaphragms here, right? Like here, you're saying we can see it extending to the anterior margin, and then the blue line, we're seeing it extend to the anterior margin. Okay. I'm not sure what the question is, but typically, if a structure is adjacent to another structure, it'll silhouette it out because they're the same density. So here, the red line, I don't know if maybe it's not projecting well, but you can see the line sort of extending anteriorly. So that's probably the right diaphragm. And then the left, or the left side that has the heart, I don't see the boundary as well. So typically we say this is silhouetted out by the heart. So this is probably the left side. Hope this helps. If it doesn't, let me know. I mean, as I mentioned, typically we have the frontal as well, so it's less of an issue, but it's just to make a point about how abnormalities can silhouette out the adjacent structures. So the difference, so the question is, how about free air under the diaphragm? What does it look like when it is supine? Free air under the diaphragm looks like, so if it's supine, so patients on their back, it'll go into the non-dependent portion. So the air will float towards the soft tissues. And depending on the extent of it, if it's a large free air, pneumothorax, or pneumoperitoneum, then it'll outline the falciform ligament, and you'll get this, what we call Wriggler sign. So we see the outline of the bowel, and then we see the falciform ligament. But you can easily miss small free air on supine. This is why if you have a high level of concern for free air, you need to request an upright radiograph so that you can get the free air under the right diaphragm. Or lateral decubitus if the patient can't stand. So the patient right side down, or the liver side is up, sorry, so it's left side down, because you need the liver to superimpose the free air if the patient cannot stand. So here is, where are we? Positioning. Okay, so we talked about that. So the difference between a PA and AP. So which image, the right or the left, so my right or the left side, which image is AP? The left is AP, yeah. Why do you say left is AP, Kathy? You're right. Why? Because it's clear of lungs. Because it's clear of lungs. Okay, so the left is AP because the heart is bigger. The heart is closer to the radiation source, so the heart projects bigger. So that's how we know. And if you look at the quality of these two images, you can also see there's differences in quality, right? So here you have, the answer is, okay. So here we have the lungs, and on the, remember we said if in a PA, which is done in radiology, patient takes a full inspiration, the arms are overhead, there's quality metrics in place. In contrast, AP, which is typically done with portable, you don't have the same metrics, so you get a lot of blurriness here, use of like very poor resolution, probably from inspiratory effort, and also the image quality is poor. So typically AP you get poor images compared to PA. What else? Okay, lateral decubitus position. So here the patient, the right side is up, left side is down. So this is, here you can see, you can sort of evaluate the volume of effusion that this patient has. This is also a good view. Remember, we want the liver side up, right? So if you're looking for free air in the belly, you want the liver on the top, and then you can see the interface between the air and the liver. If the patient can't stand up, to assess free air. Technically adequate. So when you look at an image, the first thing you have to assess is the quality of the image. The patient taking a full inspiration, do we see nice lung volumes? And then from there you can then interpret the images. So here's an example of why that's important. Here we see this opacity along the right heart border, and then we repeat the images with the patient in full inspiration, you see that opacity is gone. And so that opacity is from poor inspiratory effort. So this is why quality is really important, because you can misinterpret information if you don't have a good quality study. Penetration is less of an issue now because we're able, we're in the digital world and we can window and level images, but here you have over and under penetration, so you don't see the image boundaries as well, so you're more likely to miss things. The other thing we assess is rotation. Typically, this is more of an issue when patients get a portable radiograph because patients aren't able to turn or be appropriately positioned, but as patients should be sort of as much as possible frontal facing. And one way to assess that is to look at the spinous processes. If they are midline along the vertebral column, then you know it's a good frontal radiograph. Malrotated. So here's an example of a patient who is turned to the right. So the heart is on the right side. And so you have these lucencies here, right? Well, these lucencies here, which mimic pneumothorax, but those are all just overlapping structures because the patient is malrotated. Opacities. So which, the image on the right or the image on the left, is a mass? On the left, okay. Left is the mass. Okay, and why do you say that? Why do you think the image on the left? It's well circumscribed. Good. So you can look at the actual lesion and then sort of their morphology, right? So A. Who's A? What's your name? Annie. Okay, thanks, Annie. So Annie says the mass is on the left side because you have a nice concave margin. In contrast to the right, this image here, where it's more of a segmental, it conforms to the segment. So it's an infiltrate that it's following the bronchial branches anatomy. Incognito, yes. So looking at the morphology helps you identify which space they're in, because what you think it is, the differential diagnosis, will depend on where it is, the spatial relationship. For example, you want to know, is it in the airways? Is it in the lung parenchyma, the interstitium? Is it in the pleural space? Or is it extrapleural? And depending on where you think the lesion is, you're going to have potentially a completely different set of differential diagnosis. So looking at the morphology of the abnormality can help you localize the space that the abnormality is in. So, for example, if you look at A, what do you think about A? Is it in the parenchyma, in the pleura, or is it extrapleural, outside the lungs? Okay, parenchymal. And why do you think it's parenchymal, Veronica? Why is A parenchymal? So A is parenchymal because it has acute angles here. In contrast to, say, C, which has more obtuse angle. So if it has more obtuse angle, then it's extra parenchymal, right? So it's either in the pleural space, or in this case, it's a rib lesion, a metastasis that's invaded into the pleural cavity. And similarly, B. So you have an obtuse margin here from this pleural thickening here. In contrast to this, which is in parenchymal. But at the end of the day, you really need cross-sectional imaging, either CT, MR, ultrasound. And radiograph is, it's hard sometimes to fully characterize with radiograph. But with CT, cross-sectional imaging, you can see these and characterize these much better. So here, what we have is this broad-based lesion. And what do you think this is? Intraparenchymal, extraparenchymal? Or pleural, excuse me. Pleural, yeah. So it's broad-based. You have an obtuse margin like you have here. And not the acute margins, which we saw with other intraparenchymal lesion. And what else do you see in this image? Is that the only thing we see in this image? Yeah, we have an effusion. So we have pleural effusion. We call fluid in the abdomen ascites, and then fluid in the pleural space effusion. And we think it's malignant. Why do you think it's malignant? You're correct. But why do you think this is a malignant effusion? Not sure. So if you look, there's this nodule here, pleural metastases. There's another pleural mets here. The window is windowed to optimize the lung parenchyma, so we can't really see it, but you can sort of see the subtle soft tissue in the background. And then there's also mets. There's a little nodule here, there's a little nodule here, small nodule here. So this is metastatic disease with malignant effusion. Okay, so the right and left lung have lobes. How many lobes are on the right side?
3.
Good. And how many on the left?
2.
Good. I like the sound. It makes me feel less alone. So what separates the right upper from the right middle lobe on the right side? Which fissure? Minor or major?
Major.
It's the minor fissure. So the minor fissure separates the right upper from the right lower, and then the major fissure separates the right upper from the right lower. Right. So the major separates the upper from the lower, and then minor upper from the middle. And then the left, we only have the oblique fissures. And knowing these fissures can help you localize the abnormality again. So here's a lateral radiograph. Where we can see sort of that the right upper and the right lower is separated by the major, and then the middle and the upper is separated by the minor fissure. Okay, so here we see it outlined because the patient has a right pleural effusion. So knowing this anatomy can also help you identify where these valves are because valves, their location will vary, and the fissures can help you. Typically the fissures, is very thin. It's very thin outline, but it can become more pronounced in the setting of like pathologic process. Mediastinum and lungs. Okay, so here's the SVC. What is this structure here? Was that the minor fissure on the past slide? This is the left side. So what fissure is on the left side?
You guys can unmute yourselves and talk, FYI.
What's that?
I was just letting them know that they can unmute themselves and talk.
Oh, yes. Please unmute yourself. I know we muted everyone yesterday because everyone was in the same class, but feel free to shout out the answers. So on the left side, there's only one fissure. It's the major fissure that separates the upper from the lower lobe. The lingula is part of the left upper lobe. So that we only have one fissure that separates. On the right side, we don't see the minor fissure. It's a little bit more inferior, but it's not currently in the field of view. So what structure is this? Or sort of lives here? I guess depending on what you're looking at, it can vary, but any guesses? Okay, and then what is the structure here? The right atrium, good. So what silhouettes out, if you had a lesion that was here and you could no longer see the right heart border, where is it? Which lobe? Right upper, middle, or lower? The right heart, good. So the right middle lobe borders the right heart border. So if you see this margin, if you no longer see it, then it's in the right middle lobe. Okay? And then this is the aortic arch, and then this is the main PA. So here, this is where the main pulmonary artery lives. And typically, you shouldn't see it doesn't look like this, but if you see a large hump here, it suggests an enlarged main pulmonary artery, which can be seen in the setting of what condition? Pulmonary hypertension, yeah. Good. And then left pulmonary artery, and that's the left ventricle, you guys said, right? So if you lose the left heart border, what lung or which left lung segment is involved?
Inferior.
Inferior, okay. Any other guesses? The lingula. So you lose the lingular. So it probably means there's a lingular pneumonia or atelectasis, and lingula is part of the left upper lobe. The mediastinum and the lungs, okay, so this is the right upper lobe. You can't, it's hard to separate the lobes because we don't really see the fissures, but if you do see an abnormality, then you can use the other anatomy to then help you locate it or localize the abnormality, okay? So this is the roadmap for the bronchi. So we have the main bronchus. Remember, it's a cartilaginous structure, right? So that keeps the airways open. And then but the bronchi are not. So you can have collapse easily, whereas the main bronchus, it won't collapse unless the patient has bronchomalacia, so that it maintains an open airway. So then you have the right and left main bronchus. And then remember, the right side has 3 lobes, right? Upper, middle, and lower. And this is the intermediate bronchus, which then splits into the left and the middle and left, or lower, right, middle and lower lobes. And then the left, you have the lingular branch, the lingula, and then the apical posterior segments are part of the left upper lobe. And then you've got the 5 lower lobe segments, the basilar, right medial, lateral posterior, anterior, and the superior segments on both sides. Here is a chest CT of the lungs, and we're going to just review some bronchial anatomy, if the video will load. Okay. Sorry for the delay. All right, I'm going to advance. Maybe we'll have a better luck here. Maybe not. I don't know. Sorry. Okay. Sorry, we'll keep going because the video is not loading. I'm sorry. Maybe my Wi-Fi is not fast enough. So pulmonary vasculature typically follows the bronchial anatomy, and you have pulmonary arteries and veins. So how many pulmonary veins do you have? One, two, three, four? 4, yeah. So you have 4 pulmonary veins, right upper and lower, and then the left upper and lower pulmonary veins. And then the pulmonary veins dump into what? Atrium, right or left? Left, yeah, good. Left atrium. And then how many pulmonary arteries do you have after it bifurcates?
2.
Yeah, right and left. So then the pulmonary arteries and veins follow the bronchial anatomy. So here we have the main pulmonary artery, and what is this? So the main pulmonary artery, what are the signs of hypertension, pulmonary hypertension? So we said earlier that enlarged pulmonary artery, right? Yeah, so an enlarged pulmonary artery suggests pulmonary hypertension. So typically we say 2.9 centimeters. Another sign that we look for is the pulmonary artery should always be smaller than the aorta. So if the pulmonary artery becomes larger than the adjacent aorta, then that's another indirect sign or imaging sign consistent with pulmonary hypertension. And that's actually more predictive of pulmonary hypertension than the size cutoff, because some people can just have small vessels, especially when they're small or young. So the ratio is helps to clarify that. Okay, what vessel is this?
Aorta.
Good. And then let me see. Not sure if we're going to have luck with this. Oh, yes. Oh, it's working here. I'm not sure why it didn't work earlier. Good. So then what vessels are these?
The carotids.
Good. And then what vessels are in the back?
The vertebral.
Good. And how many branches come off of the aorta? What are the great? 3. Good. And what are they? What are the 3 great vessels that arise from the aorta? Yeah, brachiocephalic. Any other? Left common, yeah. So left common carotid and then left subclavian. Good. So what is the structure here? Or here? So it goes cranial. It's next to the esophagus, goes up, and then comes around and then dumps into the SVC. What is that? This structure? Azygos, yeah. So here's a hemiazygos, thoracic duct, and then it goes up and over, and then it comes and dives in to the SVC and dumps into the atrium. Good. And what is this structure here? It has 4 veins draining into it. The left atrium, good. And then what goes into the IVC? What the IVC and SVC dumps into what? So here we see the IVC, or the IVC, and it goes into the right atrium. Good. And then here's a coronal reformat of the image of this patient's CT. What is this vessel here? Right there. Lung. It's the internal mammary. Good. And then what is this vein here?
Subclavian.
This is, yeah, the left brachiocephalic. So it's the subclavian that then becomes, I guess, the brachiocephalic, and then goes into the SVC. So then when you have a central line, you want it, sometimes it can cause stenosis of these veins, and then you can take them out. So that's the most common cause of stenosis in these central veins. And what is this vessel here?
Pulmonary artery.
Yeah, that's the main pulmonary artery, and you see that the left goes over the left main bronchus, and that when it goes over, this is what's creating that hump that we see on the frontal radiograph, is because it's going over the left main bronchus. So, okay, we talked about this, right? So we said this is the right heart border, the right atrium, this is the arch, and then this is the aortic arch. If you don't see this aortic knob here on the left side, let's say this shadow is absent, what should you think about? Sometimes the absence of a normal structure can clue you into the underlying abnormality. And sometimes that's harder to pick up, like absence of a normal finding rather than presence of an abnormal finding. So if this is absent, then the thing that the diagnosis that has to be in your sort of in your top differential diagnosis is, yeah, dextrocardia, or yeah, so you have a right heart, a right arch. You can have a mirror arch. You know, patients with congenital abnormalities, so typically like TET, tetralogy of Fallot, other congenital abnormalities where the right side never goes to it never crosses, and so you have a right-sided arch. And that can clue you into underlying associated abnormalities. So how do you read a chest radiograph? As with most things, you want to follow a checklist. So this is a typical checklist that we follow. You look at the airways, you look at the vessels, you look at the like heart, mediastinum, pleura, bones, and then soft tissues. And depending, you come up with some systematic list, order, and then follow that every single time so that we don't miss it, right? So when we look at chest radiograph, we can only sort of analyze what sort of hits the middle of our fovea. So we can't just look at the whole thing and then say, oh, it's normal. You have to do a systematic approach so that you can sort of really carefully assess every single structure. And I think reading chest radiograph is a little hard because you can miss so much. So different people have different approaches, but here you can look at like the pleura, and then you go through and then systematically go through the lung fields, and then similarly along the lateral view. So here, this is the silhouette sign, and it was founded by Dr. Felsen, and we know it here, the infiltrate, for example, is in the right middle lobe. Why? Why do we know this is in the right middle lobe?
Clear borders.
Because the right heart, yeah, exactly. So because the right heart border is gone, so that helps you localize the infiltrate being in the right heart border. Here we have the left heart border, and similarly, it's the lingula that becomes obliterated, or this left heart border becomes obliterated if you have infiltrate in the lingula. So, question from Annie, can you go back to the description of the silhouette sign? Yeah. So the silhouette sign, it refers to the absence of normal boundaries. So similar to the left heart border, normally we could see the right heart border. Oh, got it. Okay. And then here we don't see it anymore. So it's silhouetted out because they have the same density, and so you lose that boundary. Bronchograms. There are other signs. Another one is called bronchogram. So normally we can't not see the airway, the central and the peripheral airways. But sometimes if there is an abnormality, structures that we normally don't see becomes apparent because of these abnormal infiltrates. So here we have there's an infiltrate in the parenchyma itself. So it brings out the bronchial anatomy that we normally cannot see because it's normally surrounded by normal air. And so this is called air bronchograms. So if you see the airways, and you normally should not, when we do, we think about an infiltrate. And, the infiltrate could be blood, pus, water. So it could be a host of things that are filling the alveolar airspace. And so that's called air bronchogram. Here we see, and what do you see here? Where is the air bronchogram? Is this normal?
No.
What's abnormal about it? The top, yeah. So here we see there's this, you see these air bronchograms here? These little, normally you shouldn't see them, but here we see them because there's thickening, so that bronchial airway is thickened, and then there's this fullness here. So it's hard to say what it is, but there's an abnormality, and depending on the patient's clinical signs and symptoms, then you're going to consider differential diagnosis. Oh, it's frozen. Not anymore. Okay, good. Thank you. Okay, so here there is a nodule. Where is the nodule? Which lobe?
Left superior.
Yeah. So here we see this nodule in the frontal, and then on the lateral we see that it's superior to the typical location of the major fissure. And how do we know it's benign? Or if you don't think it's benign, why is it not benign? It's not spiculated. Okay. A more important reason why it's benign.
It's not calcified.
Calcifications, yeah. So this nodule is calcified, and because you see this density here, so typically nodules that have sort of this calcification pattern are usually granulomas from prior granuloma disease, like fungal disease, whatnot. So then they calcify over time. Okay. Solitary pulmonary nodules. Okay, so where is the abnormality here? Where would you put it? Left side. Okay. Lingula. Any other guesses?
Posterior, closer to the spine.
Okay, so we think there's something here. What about on the right side? On the frontal, where do you see it? That abnormality. Can you co-localize it? It's the right heart border. Yeah, yeah, over here. So this is in the right side. Basic question. Kathy wants to know, is the patient's right always the left side on the image, regardless of AP and PA? Okay, that's a really great question, and it talks about standards. And the standards in imaging, the right side is always the right, or this is the patient's right side. Our left side is always the patient's right side, so they're facing us. Typically, the superior margin of the image is the cranial, and then the inferior margin of the image is caudal. That's the standard. Here it's obvious because you can see the patient's anatomy, but on ultrasound, for example, the superior margin always has to be the cranial, and then the reverse for the inferior margin, and that's the typical standard. What is the gray area by the left lingula area? What is the gray area by the left? This one? This one? This one? That's just normal lungs. It's the breast shadow. So you can see it symmetrically here. This is the breast. Sometimes you can see a nodule there, and that's the nipple. The first one you pointed to. This one? Yes. So this one is probably part of the pulmonary. So this is the left main bronchus, this lucent area. So this is probably the main pulmonary artery that's coming down, up and down. Okay, so you see this mass. What are you going to do next? Are you going to say it's benign? Or are you going to do something else? CT, okay. So let's say I tell you it's I don't know, it's a vertebral body is like usually 3 centimeters. So it's greater than 3 centimeters, right? So are you going to get CT so typically the guidelines say if you have a nodule that's typically 8 millimeters or larger, 9 millimeters, then you want to either get a PET CT or biopsy. So, I mean, it's because you can get more information. So PET CT, if it's hot, then it's most likely malignant. If it's or it could be malignant or infectious. But if the PET CT is negative, then you're done. It's most likely benign. So yes, Madeline. So she said if there is prior radiography, absolutely right. If it's been there for 10 years, it's absolutely benign. So comparing it with priors, and then if we don't have any priors, proceeding with the CT is reasonable, or PET CT. But whatever it is, you can't leave it alone because this is highly likely to be malignant. So they're going to need a biopsy, if not resection. Okay, so let's talk about another common abnormality, atelectasis. There's different types of atelectasis. Atelectasis means there's volume loss. So there's collapse of either the lobar or segment. And so collapse can come from different causes, right? So if you had, the most common type is called passive collapse. So if you have an effusion, it pushes on the lungs, and then it's like a mass effect. And so it causes passive obstruction. Another type of atelectasis is called obstructive. So let's say somebody aspirated something, or let's say there's an endobronchial lesion that can cause obstruction because you have a obstructing lesion. Another type is we call a cicatricial. Cicatricial happens when you have patients who've had scarring in the past, like say from asbestosis or TB or whatever, and there's scarring that causes the lungs to collapse. So typically though with atelectasis you get, because you have collapse, there's typically associated volume loss. So you get vascular crowding, you get mediastinal shift towards the ipsilateral side, and then the contralateral side, it becomes hyperinflated. And then there's hilar elevation. So the hilum will move towards the collapse, right? So you can imagine if you had one of those Asian fans, and if you close the fan, then the fissures will come with it. So it'll move towards the direction of the collapse. And that's another way you can identify which lobe is collapsed, by looking at where the fissures are collapsing towards. So here we have this tube here. It's not windowed well, but this midline tube here. So when we look at a chest radiograph, the first thing I do is look for tubes and lines. So this is not well, it's not projecting well because it's not windowed correctly, but this is an NG tube. And then after that, I look at the lungs. Look at the volume, right? It's the right and left. So here, the right looks a little smaller to me because the right hemidiaphragm is a little higher than the left. And then there's this little bit of haziness. And then I notice the right heart border's not there. So then I'm going to start thinking, okay, why is the right heart border there? So it's the absence of the finding rather than necessarily like a clear, mass or a nodule. So given these findings, what are you going to think about? Right middle lobe pneumonia. Yeah, so there's something involving the right middle lobe because the right heart border is gone, right? So you're going to think either pneumonia or atelectasis. And how do you differentiate pneumonia from atelectasis? Because they're completely different processes that require different treatment. So we said, pneumonia versus atelectasis. Okay, so with atelectasis, you get volume loss. In contrast, pneumonia, the volume doesn't change because the normal air that's typically taking up on the alveoli is now just replaced with fluid or pus or blood, whatever. So you don't get any volume loss with pneumonia. In contrast to atelectasis, where you do get volume loss because, depending on the cause of atelectasis, you have collapse. So here, the right hemidiaphragm is a little bit elevated. So I'm going to favor atelectasis in this case because you have volume loss. But sometimes you can have concurrent. How about the haziness on their left too? Is there atelectasis there too? Yeah, I mean, it's very hard to tell, right? It's hard to say, and this is why having a lateral radiograph is incredibly helpful because on a lateral, it becomes very clear and obvious. So in this case, I don't know that I would call anything. Here, I would call something just because we lose the right heart border and there's asymmetric increased density. Is there compensatory hyperinflation here? Yes. Which side? Which side do you think has compensatory hyperinflation, Madeline? Right. Yeah, I wouldn't say compensatory hyperinflation. We'll see examples of that, or clear examples here. It was just really the right main elevation, and so this is atelectasis. I forgot to mention in the lines and tubes that there's a central line here. What is this central line? So call it ask, is the right hemidiaphragm usually slightly more elevated because of the liver? And then Guerrero said, same question. It is a little bit more, but I think here, like overall, I think you have volume loss because here the left side is a little bigger, and then here the right side is like globally a little bit smaller, and then the right hilum here is pulled down a little bit. So it's a combination. The right hemidiaphragm is a little bit maybe higher, but a collection of these sort of like global volume as well as the right hilar being pulled down, and then the loss of the right part border sort of collectively suggests volume loss. Do we have? No, we don't. Sorry, I don't have the CT to show you, but this is sort of what we think about. But, you know, it has to be taken in context of the patient's clinical symptoms. If the patient has fever, has leukocytosis, you know, productive cough, you know, this is, I mean, you can certainly call this pneumonia with like superimposed atelectasis. So everything has to be taken in the context of the clinical picture. So here we have, what do we have here? So which side looks abnormal to you? Right side or the left side?
Left side.
And what's wrong with the left?
Hazy.
Yeah, it's super hazy, right? And what else is wrong with the left side? There's, you know, I mean, we can't see the right hemidiaphragm, but this looks like it's getting pulled up a little bit. And if you look at the ribs, the spacing between the ribs are a little closer together. This is suggests that there's volume loss. And then if you had a lateral radiograph, you can see, you know, you can localize it better. But typically, if it's like a full haziness like this, we see that typically with left upper lobe collapse. Which lobe is affected? So the left is abnormal. Is the left good? So this is we call this left sickle sign. Left sickle sign is, you know, like the death, like that sickle. And so what happens is the right upper segmental lobe herniates to the left side because it's hyperinflated due to endobronchial lesion, typically cancer, like bronchogenic cancer, that causes collapse of the left upper lobe. So the left upper lobe is collapsed, and so then you have compensatory hyperinflation of the right side that pooches in to the contralateral side, so then it makes the appearance of a left sickle. Here is a another patient. So when I look at radiographs, I look at the lines and tubes first. Here we have a central venous catheter that's sitting in the region of the SVC, which is normal. And then we have an NG tube, and I don't see it, maybe endobronchial tube here. Sorry, the image quality is not great. You can see it better here. The question we have from Sumed is, the white washout is due to complete collapse on the previous slide. So on the previous slide, oops, no, this is the wrong button. The white washout appearance, yes. So you can have a washout appearance. So here it's only in the left upper lobe that we see better on the lateral because we see the lower lobe is inflated. But if you had a left main bronchus lesion, like a mucus plug, then this entire left hemidiaphragm will be whited out because of a collapse from the obstruction. Here it looks like it's a whole lung, but it's just the left upper, and the reason it looks like it's a whole lung on the frontal is because the left upper, it covers the entire anterior aspect of the hemithorax. So here we have, left lower, so yeah, so before we saw like the entire opacity, here what we see is the opposite. So here the hilum is being brought down. And we see it recover here after the patient has some pulmonary toilet with, you know, inspiratory spirometer, probably pulmonary therapy. But you see the hilum being pulled down, and then in the normal retrocardiac region we sort of lose because the left lower lobe has collapsed. Most of the time, though, we see just partial atelectasis. So it's not a lobar collapse, and really just a segment of a lobe. So those are seen as linear bands. So here we see this linear band here, and it's sort of in the region of the lingula, because it borders the left heart border. Okay, and this is like much more common than lobar collapse, especially in postoperative patients. This is a terrible radiograph because it's not projecting well, but this is a lucency here, and then you see that here we lose, there's no more aeration. What about the hump along the left heart border on the atelectasis picture? Oh, yes. So the question is about this hump. It's an artifact because we see it on both sides. It's a scapula. So here's a scapula here. You can see that scapula here. So it's just from overlapping shadows that there is this appearance of a hump.
Below the arrows. I actually meant below the arrows.
Below the arrows. Below the arrows. This one? This below the arrows. This one?
Yeah, right there, right there. Oh.
Oh, yes. So this left heart, left diaphragm is high. So yes, it's a very good observation. So the left hemidiaphragm is elevated. We see the stomach bubble underneath it. So if the patient, has not had like procedures in the past that would cause them to have like phrenic paralysis, this can be contributed towards just probably the atelectasis with the volume loss, causing the hemidiaphragm to be displaced superiorly. Here, this is, I'm sorry, this is a bad, I should probably window this better, but the lucency extends to this level, and it's because of this right upper lobe collapse. Lines and tubes, we see the NG tube here, and the NG tube should be below the GE diaphragm. The side port should be below the GE diaphragm. We'll talk about that more in the GI lecture that we'll have. Right middle lobe collapse. Similar to pneumonia, if you have a collapse in the right middle lobe, you're going to lose the right heart border, as we see here. It's not as distinct, but as you see in the lateral, it's a lot clearer, the collapse that's causing us to lose the right heart border. And here is another example. So we have right lower lobe collapse. I think this is the hardest to pick up because you just have to notice this like really subtle curvilinear structure where the right side just collapsed down, and then the right hilum is also pulled down with it. But this is a very hard finding to pick up, and I think if you don't have the lateral, it's easier to miss than without a lateral. With the lateral. So what finding is least consistent with atelectasis? So we do see air bronchogram because you have collapse, and so then you bring out the airways. Crowding of the vascular markings, yeah, that happens too because you have volume loss, so all the structures get close. Expansion of the other lobes, yeah, you get hypercompensatory hyperinflation of the other lobes. Elevation of the diaphragm, it can, depending on the severity. What was the answer? Oh, okay, good. Oh, it's not A, it's E. Sorry, this should be E. Correct. So that's E. Mucus plug. Okay, so here I think someone mentioned like whiting out the hemidiaphragm on one of the prior slides, and here is an example of that. So you see a whiteout of the right lung. What else do you see? Any secondary signs? Because a whiteout can be due to different things. It could be due to, we said earlier, like an endobronchial lesion that causes collapse, but it can also be due to if patients had a massive right pleural effusion, you can also see a whiteout. So how do you differentiate these two entities, which can sort of have a similar imaging appearance on a radiograph? What are the secondary signs that we can also assess to differentiate, say, a pleural effusion from an endobronchial lesion? Any thoughts? So what do you think about the mediastinum? Which way is it going towards? Is it going shifting towards the side of the abnormality or to the other side?
Looks like a way.
It's shifting towards the patient's right side or towards the left side? Towards the right. Yeah, so here is the heart. Here's the midline of this patient. So normally the heart should live here, but the heart as well as the mediastinum is sort of shifting towards the right side of the ipsilateral side of the collapse. And then what else do you know about the left lung, right? You have hyperinflation. So these findings suggest that there's a volume lost. If, in contrast, you had pleural effusion, that's actually a mass effect. So if this was due to pleural effusion, the heart would actually get pushed to the left side, and then you have, either maintained normal lung volume on the left. So then after they, sucked out the mucus plug, endobronchial with an endobronchial scope, or aggressive respiratory therapy, they were able to reestablish a patent airway on the right. So let's talk about pulmonary edema. It's 2:10. Do you guys want to take a break, or shall we keep going? Pulmonary edema, another very common finding that we will see, especially in the ICU setting. There are two types, cardiogenic and non-cardiogenic. Cardiogenic is a lot more common just because of the prevalence of cardiomyopathy, CHF, things like that. Non-cardiac, however, you can get edema from non-cardiac sources. Here's an acronym: from near drowning experience, people who've had trauma, oxygen therapy, CNS like TBIs, traumatic brain injuries, ARDS, aspiration, altitude sickness. So these are sort of less common, but we can see pulmonary edema in those, typically young people actually. Cardiogenic we'll typically see commonly in people with older, with like CHF and whatnot. And so it's a slightly different patient population. Pulmonary edema, so if it's cardiogenic, basically we have venous congestion, right? So the heart is not pumping, and so then you have like fluid overload essentially, and so the fluid backs up into the lungs, and then first it'll go into the interstitium, and then you get these septal lines, and we'll see examples of that. And then if the pressures are really high, then it'll go into the alveoli, and then eventually into the pleural space, and they'll get pleural effusion. So depending on the severity of the edema, they can get different patterns. But it always starts central because it's usually a cardiogenic source, and then it'll start in the perihilar region and then spread. So the pattern is another important thing that we look for. So here, chest radiograph, I start with lines and tubes. So lines, we see here, patient has an ET tube, so the patient's intubated. And the normal ET tube should be like around the region of the thoracic inlet, like 4 centimeters from the carina. So this is a good position. This is where the carina bifurcates. And then we also see this line here. What is this line here? What is this central line? And is it in a good position? So we see the central line coming along the region of the subclavian vein, crosses over, and then comes down. So it's a subclavian. Okay, so what kind of line is this? It's a PICC line. So it's a PICC line. So it's coming from, they put it in the arm, usually like a brachial vein, one of the deeper sort of veins, a cephalic vein. I mean, it's not a deep vein, but it's like one of the larger superficial veins. And then they thread it into the central system. So it's a central venous catheter. And then, so this is the normal place for it. This is a good position. You want it sort of within the central region, in the region of the SVC, maybe proximal atrium. Okay, so then after that, like look at the lung volumes. Lung volumes are okay. This is a portable radiograph. You see the image quality is so-so. And then I look at the infiltrates. So right here we see, this is not, there's these perihilar opacities bilaterally. And then, you look for, there's no effusions. You can see the costophrenic angles really clearly here, so there's no effusions. Then I look at the mediastinum. The cardiomediastinal silhouette is enlarged. You have the mediastinum here is widened because of cephalization. The vessels are engorged. So you have, it sort of has this appearance of a sort of mediastinal enlarging in the background of cardiomegaly. So this is what we see with pulmonary edema. So here, what do you think? Is this pneumonia or CHF? CHF. So first I look at lines and tubes, so no lines and tubes that I see. And then lung volumes are okay, right? Now you look at the lungs and you see these perihilar opacities. Look at the pleura, they're a little blunted, so there's probably a component of fusion. Cardiomediastinal silhouette, you lose because of it's obscured by this perihilar bat wing pattern. So this is CHF, and sort of if you had to put this patient in the different stages of CHF, where would this patient be? So where, in this case, where is the fluid? Is it in the interstitium? Is it in the alveoli? Is it sort of like leaked out into the pleural space?
Pleural space.
Pleural. So there is some in the pleural space, but most of this is probably in the alveoli. And the reason we know is because it's very fluffy. It's like very fluffy opacities. If it's interstitium, it looks more like this. You can still, it's sort of reticular pattern here. Whereas if it's in the alveoli, it just fills up the sacs, little alveolar sacs, and so it looks very fluffy. And then the other thing you can see is these air bronchograms here. Because you just have so much fluid in the alveoli, it's outlining the airways that are typically not apparent. So this is CHF, and that's the bat wing pattern. So here are two subsequent images, pre and post Lasix, diuresis. So I look at the lines and tubes. So what is this tube here? So this is a tracheostomy tube, yeah. And then what is this line here? This line is, so it's an right IJ line, central venous catheter. So Sumit has a question. What's the bat wing pattern in the previous slide? So the bat wing pattern is what we see with severe CHF. It's a symmetric perihilar opacity that sort of extends out into the pleural margins, and they call it bat wing because it looks like a bat wing, and it's usually due to cardiogenic pulmonary edema. In contrast to non-cardiogenic, which does not have a bat wing appearance, you just have fluffy airspace in the lungs, not in this distribution. Just this one tells you is a cardiogenic source. Pulmonary edema. Okay, so we said this is a right IJ, and then this is, what is this line here? So it's another central venous catheter and is terminating in this sort of SVC area, and is that normal place for it? Yes, good. And so then I look at the lungs, so lung volumes. The lung volumes are kind of low bilaterally, and then I look at the parenchyma. So so you see there's like this perihilar opacity. It's pretty severe, sort of in a central perihilar distribution. The costophrenic angles I don't see well here on the right side. The left, it's excluded in the field of view. The heart is big. It's and then so this is CHF. They diurese the patient, and this is the post-diuresis films, which looks better. So we still have the central line, two of them, trach tube, and then you see that there is improved perihilar opacities. You probably still in a small effusion. Left I don't see very well, but this is better. So there's recent guidelines that came out, and they said that you should not get serial ICU films. It's not indicated. So you should not be doing this if you're in the ICU. And the only time you should get a radiograph is really if there's acute change in patient symptoms. So daily ICU films are not recommended from the ACR, American College of Radiology, appropriateness guideline. It was like a recent statement, trying to reduce cost. Okay, so here is another example. So lines and tubes, I see something here, but it doesn't look like the normal course of a normal line. So it's probably external. So quality is really important. Like that's why our technologists are taught to remove all the EKG leads and all these things that could be superimposing the image, because you can really get confused. But here, so no lines and tubes. I look at the lung volumes, which is fine. And then I look at the lungs. What do you guys think about the lungs? Normal, abnormal. Fluffy. Yeah, it's very fluffy. And it's a perihilar distribution, right? It sort of comes centrally and it goes out. And the pleural space, you don't really see the costophrenic angle very well. The CVA is sort of blunted. Patient's probably supine, so you're not going to see the normal crescent pattern because it's not going to layer. So what you see instead is this haziness that comes up because the patient is supine. Same thing on the left. So there's probable underlying effusions bilaterally. So the lungs, pleura, and look at the heart. The heart, what do you think about the heart? So the cardiomediastinal silhouette is markedly enlarged. And you look at the soft tissues and bones. Though they're probably normal here. So this is CHF. So, this is a similar image, and then this is post-diuresis, right? So much improvement. Now you can actually see the borders of the heart. Curly B lines. So remember I told you there's different severity of CHF. So first, when you have congestive heart failure, it goes into the interstitium. So you get these curly B lines. These are just the septal lines that are thickened in interstitial pulmonary edema. And then if it gets worse, then it could go and sort of like leak out into the alveolar space. And when it does that, it looks fluffy because it's in the alveolar space. But I mean, having a fluffy pattern opacity doesn't always necessarily mean edema, right? Fluffy pattern just means there's something in the alveoli. It could be water, fluid. If it's edema, it could be blood, it could be hemorrhage, or it could be pus, pneumonia. So different causes. So it's not necessarily specific. That's why you have to take in the context of the patient's presentation as well as other imaging findings. Here we see, marked cardiomegaly. The patient has an AICD lead, so there's probably underlying cardiomyopathy as well. So this is what curly B line is interstitial edema. But it's not specific, right, for cardiogenic edema, because you can see these other settings where you have thickening of the septum. For example, interstitial fibrosis, you can get malignant lymphangitic carcinomatosis, pneumoconiosis, things like that. It just means the septa are thickened. Here, so Annie has a question. What would you say about the lung volumes? So the lung volumes on the prior slide here, I'd say it's normal. I mean, it's maybe a little lowish, but it's not too bad. That was CHF 2 slides ago on the other side. Here? This one? Yes. Lung volumes are fine. Heart is markedly enlarged, but lung volumes are fine. Let's go back to, where were we? Near drowning. So, right, so chest radiograph, lines and tubes first, always. So I don't really see any lines and tubes. Look at the lung volumes. It's probably okay. I mean, it's not great because the ribs are kind of close to each other. So this is not in a full inspiration because the ribs are close together. There's rib crowding. And then you look at the lungs. What do you think about the lungs? Normal lungs, abnormal lungs. They are hyperinflated. I wouldn't say they're hyperinflated because in patients with hyperinflated lungs like COPD, the diaphragm is flattened. And here the diaphragm is normal contour. Decreased volume, yeah, so it's hypoinflated, correct. So it's low lung volumes, and then the ribs are closer together, closely spaced, so you know that there's volume loss. And what do you think about the parenchyma of the lung? Is that normal appearance? You see, we can see the airways here. It's hazy, yeah. There's this like opacity, right? Fluffy opacity. Let's say you have a history of non-drowning. What are you going to think now? Near drowning, excuse me. So it's pulmonary edema from non-cardiogenic source, right? Because yeah, exactly. So the heart is normal in size. And is this a PA radiograph or an AP radiograph? Probably an AP, right? Heart looks a little bit more prominent, which we see typically with AP. Clavicles are a little bigger, so this is an AP radiograph. What is the likely diagnosis here? So this was our quiz questions. My friends, what do you guys think? Pulmonary edema, perfect, right? CHF. This is like CHF, no question. Okay, in contrast to so another common finding that you guys might come across is pneumonia. Lots of different types of pneumonia depending on like the extent of it. So you can have lobar, you can have lobular, you can have, depending on the patient's clinical scenario, aspiration. Aspiration pneumonias tend to be in the basilar predominant because it goes in the dependent spaces. You can have infections, right? So you can have mycobacterium. So a lot of this happens with the clinical presentation. So to differentiate pneumonia and atelectasis, you have to look at these secondary signs. Atelectasis are associated typically with volume loss in contrast to pneumonia, where the volume is typically maintained or if not increased. You get the shift. So if you have atelectasis, it's ipsilateral, whereas pneumonia, there's typically no shift. Atelectasis is usually along the segment of the lung, in contrast to pneumonia, which is usually infiltrative and can be multifocal. And then atelectasis, the apex is at the lungs. Remember, it's like those Asian fans. If you close it, it's going to come to the apex. Whereas pneumonia does not necessarily follow the apex. So here is an example of what? Pneumonia, because why? There's no collapse. And there's infiltrative, right? There's no volume loss. And hopefully the patient will have signs of infections. What about here? Pneumonia or atelectasis? Atelectasis. Why do you think it's atelectasis? Volume loss? Pneumonia? Okay, why do you think it's pneumonia, Madeline? Retraction of the hilum? No hyperinflation, no compensatory. So the hilum is the hilum is here. So here's a carina. And so you see the right and left main. It's hard to see. But this is pneumonia, and it's pneumonia because of the distribution. So you have this interstitial pattern, and it's not along a segment. We don't really have maybe a little bit of volume loss, but not significant. Certainly not enough to explain this infiltrative process. This is the right upper lobe, right? If it was the right middle lobe, the right heart border would be out, but here the right heart border is maintained. The right lower lung field are clear. On the lateral radiograph, we see that airspace opacity here, filling up this space here. So there's not really much volume loss, and there's all of this fluffy interstitial as well as alveolar opacities, which we don't typically see with atelectasis. Atelectasis is more linear in shape, and it's usually well demarcated because it typically follows a segment or a lobe. Here, it does neither. So this is pneumonia. So here, what is the likely diagnosis? Any guesses? Pneumonia. Right upper, right middle lobe pneumonia. Right middle, no, right middle. Okay, why do you think is right middle lobe? Why do you think it's right middle lobe? So here we see, what do we see? Looks similar to the last image. Heart border is not clear. So here's the right heart border, but I would give you that the sort of the hilar area is obscured, right atrium. So here it is, I would actually call this right upper lobe because we can see the right heart border. Normally, if it was in the right middle lobe, we lose this border here. Oh, no. Wait, you said right middle lobe, right? Yeah. So if it was right middle lobe, it would be obliterating the right heart border, the right atrium. But we see it intact here. So this is why it's not right middle, it's right upper. But everyone had the same response, right middle lobe. So I'm not being clear about something. How can I? So everyone thought it was right middle lobe because the right heart border was not clear, like this border here. Would it be at the bottom of the right upper lobe? Yeah, so here would be the anterior segment of the right upper lobe, correct. Okay. Okay, oh, TB. Let's talk about TB briefly. So TB, there's two types of TB. Primary, where it's like an initial infection, and that typically presents with hilar adenopathy. You get like this sort of airspace opacity, almost like a pneumonia. Gone's focus, they call it, specific to TB. But you can't really differentiate that from other pneumonia per se. In contrast, reactivation TB or post-primary TB, that's usually presents in the more oxygenated part of the lung. So we think like lung apices, the superior segment of the lower lobes, are typically where reactivation happens, in contrast to primary TB, where you don't necessarily have that geographic preference, and it's more hilar adenopathy. Okay? So we typically use chest radiograph to screen, but I mean, really, you should be just using quantum Farron gold, which is way more sensitive, right? Because radiograph, you're not going to see it until there's structural changes. So if you see it, yes, there's obviously a thing, but in the absence of it, you might still have TB. So I think the better way to go about this is through quantum Farron gold. But here we see this. So where is the abnormality? Yeah, left apex. And what do you see in the left upper lung fields? So there's like interstitial markings, and it's not really projecting well, but there's a cavity. So here. So is this a primary or secondary TB? Primary or reactivation TB? Reactivation, yeah. So it's usually people who had an initial infection, and this reactivation, we get the cavitary cavitation. Okay, in the typically oxygenated, more oxygenated part of the lungs. So here, what do you see? So we have a frontal and lateral radiograph. So there's no lines of tubes. And the lungs, what do you think? The lung volumes, what do you think about the lung volumes? It's probably a little bit lower, okay? And then what about the lungs itself? What do you guys think about the lungs and the pleura?
The left side is less.
The less what? Less volume? Less bulging of the left angle. Here? Blunting. Oh, sorry. Yes, there's blunting. So the left side is blunted. Yeah, so you have an effusion. And here we see this hazy pattern in the right upper, right? Sort of this opacity. And then you have like a large effusion. So you know, this pattern, it's a differential diagnosis. So it could be anything that fills the interstitial and the alveolar space, right? So we said it could be fluid if it's edema, but this is not the typical distribution for pulmonary edema, right? Which is usually perihilar. It could other things that can fill the alveolar. You could pus, pneumonia, right? So definitely, certainly pneumonia. Other things, blood can fill the alveolar space, so it could be hemorrhage, which is what this turned out to me. But a lot of it has to be taken in the context of the clinical situation context. Here we have a large left effusion. It's up here. The patient also has a right effusion, which we don't see in the AP view. So we called, because the effusion is primarily layering in the posterior claustrophrenic angle, or the diaphragmatic angle. So they call this like subpulmonic effusion, and we don't see it layering here because it's in the posterior aspect. But there's no way to say with certainty that this is hemorrhage, right? Hopefully the patient is presenting with hemoptysis, rather than like productive cough and fevers. Let's talk about PE because it causes a lot of morbidity and mortality. Patients, 10% result in pulmonary infarction. A lot of people get PE. They get, shortness of breath, dyspnea, and there's sort of primary and secondary signs that we see with imaging. So here we see sort of more end-stage PE. So right here we have a patient, look for lines and tubes. There's no lines and tubes. And then look at the lung volumes. It's a little bit lowish on the lowish end. And then but then you see this opacity in the right claustrophrenic angle. So if the patient is dyspneic and short of breath, does not have leukocytosis, there's no productive cough, no fever, what you're going to think more likely it to be PE, right? And then you see a similar peripheral consolidation in the left on this patient. So this is called Hampton's hump. And this is the segment of the lung that's been infarcted out from the embolism. So this is end stage. Most patients don't present with this. So most patients with PE present with what finding on chest radiograph? Normal or abnormal finding? Normal. Most people with PE have normal chest radiograph. So a chest radiograph is not done to rule in TB, it's to rule out other causes of shortness of breath, such as pneumonia, such as consolidation, such as anything else, right? So a negative chest radiograph doesn't mean the patient doesn't have PE. It just means the patient doesn't have clear evidence of other abnormality. So Kathy's question was, how do you know if it's low or high volume? Count the ribs. Yeah, you can count the ribs. A lot of it is just sort of qualitative. Normally you can cut the ribs and it should be 12, 12. And the eighth rib is the anterior part, and then the posterior diaphragm goes all the way down to T12. But then you sort of look at the whole thing. So here the patient, look at the rib, the diaphragms. Normally it doesn't, it looks a little bit more concave. Like here, for example, right? So this one is a nice full inspiration. This patient is not like taking a full breath because here the claustrophrenic angles go all the way down here. So it's a combination of qualitative and quantitative. Now, what is the abnormality here? Oh, we said this, right? I think you guys all got it. It was Hampton's hump from an infarct. So this patient has a PE. And like I said, we don't really see this because this is more end-stage findings. And you need a CTA if the patient has like high level of suspicion and negative chest radiograph and D-dimers are elevated. Pleural effusion, that just means fluid in the pleural space, and there could be a lot of different kinds of, right? The pleural could be, again, water, blood, pus, anything, depending on the patient's underlying symptoms. But when we have pleural effusion, if the patient is upright, then we'll see blunting of the claustrophrenic angles like this, okay? It could be blunted anteriorly or posteriorly. If the anterior is blunted, you're more likely to see it. If the posterior is blunted, it's better to see it on a lateral radiograph. They call it subpulmonic effusion because you don't really see it well on the frontal. Again, what kind of effusion it is, it doesn't tell you what kind of effusion it is. It just tells you that there's an effusion. So here, so there's an effusion. The pleura is enhancing. This is a contrast enhancement because the aorta is bright. And you see that this has a bulging effect. The fluid is not simple. A simple fluid would be iso intense, and this one is a little hyper intense. And with the thickened enhancing pleura, you're worried about a non-simple fluid. So in this case, this is empyema. Empyema is pus, basically pus, like an abscess in the pleural space. And this is important to know because of why. How do you treat empyemas? Drain, yeah, exactly. You have to put a percutaneous pigtail catheter and then drain it because it's not going to respond to IV antibiotics. And if it becomes really severe or refractory, then they can do pleurodesis. Here is a patient with a cavitation in the pleural space. So whenever you have air, you start to think about a superimposing gram-negative bacteria or just like superimposed infection in general. Okay, let's talk about pneumothoraces. Oops. So pneumothoraces is when you have air in the pleural space, and the way you know is to look for these really fine lucency that extends beyond the pleural margin. So here, the pleural margin is right here. So there's no there's no lung markings beyond it. Here is more obvious. You have the pleural marking that extends to here. So this is pneumothorax. But this kind of pneumothorax actually, and then sort of it posteriorly or anteriorly, it sort of bulges probably posteriorly down here in the posterior mediastinum. This is a special kind of pneumothorax because the heart is being displaced. And what is that called?
Tension pneumothorax?
Yeah. So when you see a tension pneumothorax like this, like you have to put a needle in there really fast because the patient can get cardiac compromise from the mass effect that pushes on the right atrium so you don't get any heart return, and then they can go into cardiac collapse pretty fast. So you either put a chest tube, or the easiest thing is to do is just take a giant, large, like an 18 gauge needle, and just stick it in the inner space so that you have something to release the pressure very fast. You can have air in the pleural space, or you can have air in the mediastinal space. So if it's in the mediastinum, it's in a different location. It's usually paramediastinal, and that's called pneumomediastinum, which is a different space from the pleura. Here we have, again, this lucency here, right? So this one, patient is probably supine, like on their back, and so the air is probably going into the non-dependent portion, so that's why it looks like it's here. If they stood up, it should rise to the top. Here we have, it's similar, right? The patient is like supine, so the air is going to the non-dependent portion, so they call this the deep sulcus sign. Remember, the CVA should just go, claustrophrenic angle should just extend here, but here it looks like it's really deep because they're supine. This is where you have both air and fluid in the pleural space. We call this hydropneumothorax. We know there's air because we see the pleural line here. We know there's fluid because we see this pleural of fluid level here. So this is a hydropneumothorax. Quickly, interstitial fibrosis is when you have scarring of the interstitium. And it could be from different causes. Most common cause is idiopathic IPF, interstitial lung disease. But you can have a lot of other causes. You can have pneumoconiosis. You can have secondary causes of interstitial lung fibrosis, such as rheumatoid arthritis, scleroderma, a lot of different causes. But on chest radiograph, they look like interstitial markings, sort of these fine reticular markings, because the interstitium is scarred down. And depending on the severity, the image appearance will vary. But here, so I go through the lines of tubes. There's none. Lung volumes, it's sort of on the lowest end. The right hemidiaphragm is a little elevated. But I look at the lungs, there's sort of increased interstitial markings, but no consolidation. And then look at the mediastinum. It's not really enlarged, but the pulmonary artery looks a little big. So you can get PAH, pulmonary arterial hypertension, in patients with interstitial lung disease. Yeah. Okay. Emphysema is when you have destruction of the lungs, typically from smoking. So patients lose the normal elastic coil of the lungs, and so they get hyperinflation. So here, the lung spaces, the rib spaces are enlarged, the diaphragm is flattened, and you have increased lucency because you have destruction of the lungs. Okay? Rib fractures, we usually get rib fractures in patients with like trauma, but it's hard to see if it's not displaced. So we can only see it well if it's a displaced rib fracture. So here, you know, it's very hard, and so it's clinical, you need clinical context, right? You're like, oh, it's the right lower area. So then you'll look closer and you're like, oh, wait, there it is. There's the displaced rib fractures. But we do chest x-ray not to diagnose rib fractures per se, but it's to look for complications. So they get pneumothoraces, they get pulmonary contusion. Sometimes they can get hemothorax from rib fractures. But in the absence of those complications, it's treated conservatively. Here is a patient who has multiple rib fractures, which we can see here, here, and here. And the problem with multiple rib fractures, as you can see here, is you get this it's this opposite effect, right? So they call this, what do they call this? Flail lungs, right? So it's doing the reverse of what it's supposed to do when the patient inspires and expires. And that's problematic because you lose the normal function of the air. And if it's large enough, it can cause respiratory compromise. Other things, we can have masses. So here we see, what do we see here? So we have a frontal and a lateral radiograph. So no lines and tubes. Lung volumes are fine. Lungs are clear. Now you look at the mediastinum. It is grossly abnormal. And where would the abnormality be? In the anterior, middle, or posterior mediastinum? Excuse me, sorry about that. Why? Yes, it's anterior. Why? In front of the esophagus. Yeah, so where is the esophagus? In the anterior or middle mediastinum?
Middle.
Yeah, it's in the middle. So we know it's anterior because the retrosternal airspace is gone. So normally behind the sternum, you should have air. And here the air is effaced because of this mass. So it's an anterior mediastinal soft tissue density. So we really need to have chest CT, cross-sectional imaging, you know, and then, but the differential diagnosis, it's going to be the 4 T's, right? Teratoma, terrible lymphoma, thymoma, and thymic neoplasm carcinoma. Okay, what about here? So no lines and tubes, there's none. Lung volumes look okay, it's not too bad. And then you look at the lungs and pleura, and lungs and pleura, there's not a clear, you know, the right is fine. The left, though, what do you think about the left? Or what's going on here? Any guesses? Possible thing. So there's this mass here, right? So along the left hilar region, there's the mass. It's actually kind of hard to see on the lateral radiograph, but you're going to definitely need a cross-sectional imaging. So the patient goes on to get CT scan, and there is this mass here in the anterior mediastinum, what was consistent with thymoma. Middle mediastinal masses, these are very hard. So you have to go along, so lines and tubes, there's none. Lung volumes are fine. And then you look at the lungs, so the right is fine. The left, what do you think? What do you guys think? Is there an abnormality? And if there is, where is it? Something at the aortic arch. Yeah, right? This thing here. And where are you going to put this? In the anterior, middle, or posterior mediastinum?
Middle.
Yeah, so we see it here overlying the posterior column, the vertebral body column. So it's behind the main bronchus, and then sort of superimposing, right? So this is typically you have this fluid attenuating lesion. So because it's fluid, you're going to think along the lines of that. So maybe like a bronchogenic cyst. It doesn't look soft tissue-y. You can the contrast enhanced. This is a contrast enhanced study because the aorta is bright, and we don't really see any enhancement. So it's probably a bronchogenic cyst. Okay, so here's another similar finding. So up high, and then it's hard to see because we have it's over penetrated, but we could probably window it. But we need cross-sectional imaging because here we see that it's a aneurysm, not a mass. So that's why we really need cross-sectional imaging. Here is no lines and tubes, lung volumes are fine, and then you go through the systematic process, right? So here, where's the abnormality? So this is one of the sort of blind spots is the apices. So we have to really look carefully at the apices, and the other blind spot is in the subdiaphragmatic region. Remember, the posterior diaphragm goes all the way to T12. So that part of the lung we don't really see very well. And then the hilar, right? So those are the blind spots for us. So close eye there. Okay, we talked about putting lesions into different spaces. So here we see this mass here. I mean, it would be very hard to put into a space looking on this like radiograph alone, but I mean, I would probably say this is an intraparenchymal lesion. But radiographs are hard. We really need cross-sectional imaging. What is wrong with this image? Or what's wrong with this patient? Any guesses? So no lines or tubes. The lung volumes are probably okay. And then you look at the lungs. Enlarged mediastinum, right? So enlarged cardiomediastinum silhouette. So there's cardiomegaly. But is enlarged cardiomediastinum can be due to cardiomegaly or another condition? What's another condition that can cause enlarged cardiomediastinum silhouette?
Pericardial effusion.
Yeah, exactly. So can you tell the difference? Sort of, not really. Some people say that pericardial effusion, you can have this bottle appearance. Boot sign, maybe. It's usually maybe. I think they call it like a bottle appearance. I think the boot sign is for patients with like tetralogy flow. Is that right? But you can have so that's why we have to say it's an enlarged cardiomediastinum silhouette. We don't know if it's really cardiomegaly because if it's pericardial effusion, then it is a completely different treatment. So that's an example of pericardial effusion, which is just effusion in the pericardial space, and that's a different treatment. So here we have chest radiograph, so no lines or tubes. There's clips here, and there's patient probably had a cabbage. There's clips along the mediastinum. Lungs are clear, and then you look at the mediastinum. What do you think about the mediastinum? Normal? lines. There's these lines, right? These lucent lines. And so this is what we typically see in the setting of pneumomediastinum. And that could be from a lot of different causes. Here we see a chest radiograph, or chest CT. So you see air in the soft tissues in the mediastinum. And so it could be from esophageal